Rosaly Correa de Araujo, who's been a colleague of mine for some time, couldn't be here. We thought she was going to be able to attend remotely, but that was not possible as well. So what she really wanted to focus on, and I'll do my best here, is really to try to talk about what the National Institute on Aging has done and contributed to sarcopenia research. And they've actually, and this is just really, I think, a sampling of some of the things that they've promoted and participated in, because I think if you dive deeply into their portfolio, there's quite a lot of projects that are focused on muscle and interventions that are targeting skeletal muscle in older adults. And she has nothing to disclose. This is just an overview. So I think some things about terminology, some issues about the operational definition, again, a little bit more deep dive into the ICD-10. This very important epidemiological analysis that was done under the auspices of the Sarcopenia Definitions and Outcomes Consortium, which I actually participated in. And then Rosaly was instrumental in getting support and holding this workshop on the development of function-promoting therapies in older adults. And this really overlaps tremendously with the interventions and therapies that we're thinking about in the space of sarcopenia. And then probably the largest thing that NIA has been supporting recently is this large longitudinal cohort study called the Study of Mobility and Muscle Aging, or the SOMA study. So just importantly here, just a little bit deep dive, there has been this evolution of the operational definition of sarcopenia. I didn't talk about this too much in my presentation, but the early definitions of sarcopenia really were based exclusively on low muscle mass and the relationship of muscle mass in specific ranges of reference populations. Without too much concern about whether this low muscle mass was linked to any bad sort of distal clinical outcomes. The work by some of these consensus panels, the European Working Group, the International Working Group, the Society for Sarcopenia, Cachexia, and Wasting Disorders. It's amazing I can remember all those acronyms. But anyway, don't ask me another one. So, considerable advance by adding performance criteria to the definition. So, linking low mass with muscle weakness, and also reductions in physical functioning, walking speed, ability to climb stairs, ability to get up out of a chair. And then with support from the National Institute on Aging and the Foundations for NIH, this sarcopenia project that was led by Stephanie Studensky really used regression tree classification analysis and again, pooled epidemiological data sets to really identify criteria for clinically relevant low muscle strength and low lean mass. This was an important project driving and moving towards more evidence-based definitions of sarcopenia. And then the adoption of some of these criteria by other regions and countries internationally has also further advanced the field. And the NIA really was very involved and very supportive of some of the evolution of this definition. They participated in the effort, along with a lot of other people, to really get sarcopenia into the ICD-10 code in 2016. And this is, I think, a necessary step. I don't think it's sufficient, because we don't really know what the utilization is of this code, but it has to be on the books before it can be used. But I think the next step is really to, again, promote awareness and get providers to start thinking about sarcopenia and coding for it. The Sarcopenia Definitions and Outcomes Consortium really was designed to refine some of the previously established diagnostic cut points for sarcopenia, test their association with different outcomes, again, clinically important distal outcomes like disability, mortality, falls, hip fractures, and hospitalizations, and then apply them in other clinical populations to evaluate sarcopenia prevalence, and conduct a public review of data analyzed from 8 prospective observational studies. So this was, again, a pooled epidemiological longitudinal cohort analysis, which really, for the first time, developed clinically important cut points for muscle weakness or low hand grip strength. That's what they are here. And slowness, having a walking speed less than 0.8 meters per second. And I think personally, this is the best we have right now for a clinically useful tool to define who has sarcopenia and who doesn't. And you may scratch your head and say, well, what about muscle mass? Why aren't we measuring muscle mass? And I think the reason is that we don't really have a good direct measure of muscle mass that we can operationalize in the clinic very easily. People have used DEXA, dual energy X-ray absorptiometry. Many of you people are probably familiar with that. Lean mass from DEXA has not been shown to be a really strong predictor of some of these distal hard clinical endpoints. And we've been very reluctant to use it and embed it into our operational definitions of sarcopenia at the present time. That doesn't mean muscle mass is not important, but I think we have to think about more direct measures of muscle that might be able to be incorporated into this definition. But right now, I think this is what we have, and I think this is operationally a very good, clinically useful definition of sarcopenia in men and women. And then the SOMA study is really designed to further address relative importance of muscle mass and strength in older adults. They also are leveraging their ability to assess muscle quality at the tissue level. So all of the participants in SOMA are getting percutaneous needle biopsies of the vastus lateralis muscle, primarily to look at in vivo and in vitro mitochondrial function, to understand how mitochondrial function influences mobility with aging, and also identifying novel tissue targets. In addition, contractile function, fiber type, grouping, other measures in aging biology of muscle that may contribute to incident mobility disability. And they're also using some more direct measures of muscle mass in this cohort as well, the D3 creatine dilution method, which is an isotopic method to look at the creatine pool size in humans, and multi-slice MRI to look at muscle volume in these samples. And then one of the studies that Rosaly didn't include that I took the liberty of including, this is a workshop, very important, that Rosaly led along with Shally Basine to the development of function promoting therapies, public health need, molecular targets, and drug development. This workshop really covered specific molecular targets in skeletal muscle that could be utilized to improve muscle function in older adults, the design of clinical trials, what was needed in clinical trials really to get some of these interventions across the finish line and to regulatory approval. And I think the great thing about this, that this was all published in all the papers from this that came out of this this workshop were published in a supplement of the Journal of Gerontology for Medical Sciences, so they're out there now. And this was really, really heavily supported by the National Institute on Aging. And then finally, I think importantly, the NIA supported this very large randomized phase 3 multi-center trial. This was a physical activity intervention, but this was probably the largest intervention study that really was designed to target older adults that had deficits in mobility using sort of a geriatric approach to the study design. So this was, we randomized over 1,600 older adults that had some deficit in their mobility across 8 clinical centers, followed them anywhere from 2 to almost 4 years. They were randomized to this intervention of exercise, aerobic plus resistance exercise versus health education. Again, this was supported by a U mechanism through the National Institute on Aging. And the primary outcome of this was to ask the question about whether randomization to the exercise intervention would prevent the onset of major mobility disability in these older adults that were at risk for developing disability. The primary outcome of major mobility disability was defined as the development of the inability to walk 400 meters. So what does that mean? Well, everybody at baseline in this trial had to be able to complete a 400-meter walk within 15 minutes. And then their ability to walk 400 meters was assessed every 6 months during the trial. And we basically just compared the outcomes in the individuals who were randomized to the physical activity intervention versus the health education intervention. And you can see that in blue here, the individuals that were randomized to physical activity, fewer of them developed the inability to walk 400 meters than those that were randomized to the health education control group. And the hazard ratio was a reduction of about 18%. This was clinically significant and I think statistically significant and clinically meaningful. So this was a major undertaking. This is the largest trial of physical activity that has ever been done in older adults and is likely not to be repeated. You know, I think without the support of the NIA, a lot of these initiatives wouldn't have happened and wouldn't have been moving forward and continue to move forward in the area of sarcopenia. So just a few discussion points that Rosaly wanted me to make. There has been a substantial increase in the number of older adults living with a physical disability, and it is anticipated due to the rapid growth worldwide of human populations over the age of 65 years. This is a public health issue. I showed you data in my presentation for the United States, but this same thing is happening in worldwide. It's happening in high-income countries, middle-income countries, and low-income countries. It's happening everywhere. There are more and more older people living to older and older ages. We really have to do something. Think about this. Partnerships at national and international levels, academia, industry, governments, professional societies, and patient advocacy organizations are needed to speed up patient education and drug therapeutic development to enhance the health, functional independence, and quality of life of older adults worldwide. So on behalf of Rosaly, thank you all very much for your listening.